Good afternoon. Thank you very much for the introduction, and let me thank the organizing committee for accepting this case and to share the knowledge with you. I have no disclosure concerning this case. This is a 60-year-old female who is really obese. Her BMI is 58. She has a history of diabetes and hypertension, severe symptomatic aortic stenosis with a mean gradient of 56 millimeter of mercury on echo, 83 millimeter. The peak gradient by cath is 83 millimeter. She has chronic diastolic heart failure with class 3. Her ejection fraction is 60%. She has chronic hypoxemic respiratory failure on home O2. Her respiratory function test is significantly reduced. Her coronary angiogram showed patent coronary arteries. Her CT angio showed that the average diameter for the annulus is 24 millimeter, and her sinus of valsalva diameter were on the borderline, and the other findings about the coronary height was 9.9 millimeter on the left and 14 millimeter on the right. Her CT angio for the femoral were okay, showing patent femoral artery. She was turned down for surgical aortic valve because of her BMI and other comorbidity, and all the peripheral vessels were adequate for TAVR. As we said, her left main coronary height for the left main is 9.9 millimeter, and the sinus width is 28 millimeter. Both of them are borderline, so there were some concern about left main obstruction. However, we felt that this obstruction is unlikely, especially when we use the balloon expandable valve. We decided to attempt the TAVR from the right femoral axis, and did that under conscious sedation, and we plan to implant 26 millimeter Sapien 3 balloon expandable valve. And we selected that valve because of the concern on the ability to visualize the borderline coronary heights. So right transfemoral access was obtained using ultrasound guidance. Triple pre-closure were used, and the S3 delivery sheath placed and received heparin. Pigtail was put from the right radial axis, and pacing lead was put from the right jugular vein. This is the implantation of the balloon expandable valve after pre-dilation with 20 millimeter balloon, and this valve was 26 millimeter Sapien 3. Just immediately after valve implantation, she became hypotensive, and the transthoracic showing wall motion abnormality. So we started CPR, intubated the patient, and started pressors, and the root shot showed the left main is occluded, as you see here. So quickly we put 6 French guiding catheter, 6 French XP LAD guiding catheter, and we were able to engage the subtotally occluded left main. And we directly put 4.5 by 22 drug-eluting stent deployed in the left main through the struts of the valve, angiling the left circumflex enough and creating snorkel segment to traverse the left cusp leaflet. So this is after the implantation of the stent, showing a patent left main, and we said this is success and the blood pressure stabilized. So we decided to do the IVUS, and this is the IVUS of the LAD showing no lesion, but however this is the IVUS of the left main showing oval left main due to compression from the leaflets of the original valve. So we did post-dilation with 5 millimeter NC balloon up to 16 atmosphere with full balloon expansion. However, the repeated IVUS showed minimal improvement in the expansion. So to improve the radial forces, we decided to implant another drug-eluting stent in the area, and we used 5 millimeter by 80 millimeter drug-eluting stents placed inside the first stent snorkel position and dilated that with 5 millimeter NC balloon up to 16 atmosphere. The IVUS at that time after the implantation of the second stent showed improved expansion, so still there are some ovoid deformation. So in order to improve the angiographic and the IVUS situation, we decided to use an ostial flash balloon to flare the snorkel stent for future re-entry. This could work, this is a snorkel outside the stent frame and not through the stent frame. So we did the snorkel and the ostial flash balloon, and we decided to put another CC, just a little extra volume in the flash balloon and the flash bulb syringe to see it might expand the ostium of the stent. However, the bulb, as you see, went up distally and flashed the distal part of the stent and caused this bulging. Now everyone went into just shock when we saw that, and this is the immediate angiogram showing a huge perforation, and the patient went into cardiac arrest. So thank God there were a surgeon around, subxyphus surgical pericardial access obtained, and we inflated 4 by 20 balloon prolonged inflation in the LAD while someone was running to get the covered stent. We put 5 by 22 millimeter biparous covered stent deployed in the proximal LAD just before D1. And after more post-dilation was 5 millimeter balloon, we were able to stop the extravasation. After that, we did the closure of the access, and the patient left the cath lab with adequate cardiac stroke volume and adequate cardiac output. Her cardiac index was 2.8 at with pressors. The learning point that we need to get careful attention to risk of obstruction, especially if the coronary height are not low. So if the height is around 10 or below 10, there is a 5% incidence of occlusion. The IVUS snorkel result should be used when possible. Second layer of stent may be required in the snorkel for enhanced radial stents to encounter recoil and deformation from the obstructing leaflets of the valve. Austere flush balloon, especially used in this way, may not work, and never add volume to flush valve. And remember, always the enemy of good is perfection. Thank you very much for your listening. I'll be happy to take any question.